Jacob Rich, thanks for joining me.
Pleasure to be here, Stephen.
So the opioid crisis has become something of a shorthand for politicians to talk about the downturn of middle America, the plight of working people, and it's something that they talk about a lot, but with very little depth. What do you think that the political class gets wrong about the opioid crisis and the way they talk about it, the problem and some of the solutions?
Probably one thing that the political class gets wrong about the opioid crisis is thinking that it's reserved to middle America and to Americans that have basically existed on the bottom rungs of the income ladder. It's affecting large communities, small communities, rich and poor, basically every single type of person in the United States, if you define them by age, race, sex, has seen a major increase in drug deaths. And not understanding our public policies' influence on those deaths is probably the biggest thing you're getting wrong.
Yeah, you often most just hear about working class, white farmers living in Idaho or Ohio, that they're the only people who are engaged actively in the opioid crisis. How does it sort of look different in different parts of the country? So, you know, like the urban version versus sort of how it's panning out in more rural areas. What have been the differences?
Well, it is true that states like West Virginia and Ohio, so West Virginia is known for being particularly poor and having a lot of people on Medicaid and using other social services. But Ohio is a little bit more rich. Those are the two states that have the highest opioid death rates.
Okay.
West Virginia is number one, Ohio is number two. Ohio happens to have the most opioid overdoses in the country, though, just because it's a bigger state. So you do see lots of overdoses in communities that have been economically hurt in the last 20 years. However, if you rank all of the states by their opioid death rates, Washington, D.C. makes it into the top 5. And it beats out many other states that are much more rural and poorer than Washington, D.C. Washington, D.C. exists with probably some of the richest people in the world. Mm-hmm. It's debatably the richest place in the world. Many of the richest counties in the United States surround the city. And they have just as high opioid death rates as states like Florida, Pennsylvania.
We're talking about the same kind of pills and delivery mechanisms for these drugs, or is it a much different problem? We're talking about, you know, heroin and things injected versus pills.
It's pretty consistent across the country with the states that are experiencing increases in death rates. Just because drugs, when they enter the black market, can proliferate around the country pretty easily. So the types of drugs that are consumed are much more a consequence of the demand for a specific type of drug.
Okay.
So if there's states that like opioids, they're probably going to be consuming incredibly similar types of opioids.
By your approximation, has there been any meaningful legislation that has come out and been signed into law to address this issue?
So that's the Support for Communities and Patients Act, some sort of a support act. It's a big acronym of some sort. But basically, it's a $4 billion that Congress has allocated to fighting the opioid crisis. The majority of it, it's about 50 bills long. So going through
it's
each
an
of
omnibus,
them,
right?
It's an omnibus, basically. Going through each of them, the majority of it's just virtue signaling, in my opinion. There's a couple things that the bill will do that will improve the situation. At the moment, doctors can only, if you receive a license to prescribe buprenorphine, which is an opioid that doctors prescribe for people who are addicted to opioids.
Yes.
It helps them wean themselves off, and it can be used as a replacement for heroin. At the moment, you need a license to prescribe it. And at the moment, you can only see up to 100 patients if you've had about 2 years of training. So you get your license, you can only see up to 30 patients. After you do that successfully for a year, you can see 100. With that bill passing, the cap is going to be extended to about 280 patients per licensee who has had a couple years of experience prescribing buprenorphine. But unfortunately, if you look at the number of people who have licenses and multiply that by 280, it's nowhere near enough to cover everyone who suffers from opioid addiction in the country. So it's a move in the correct direction, but the resources and laws do not allow us to basically treat every single person with opioid addiction if you think they should be receiving medication-assisted treatment.
Is that tied just to the issue of the cap on how much service they can provide, or the actual shortage of physical doctors around the country to work on issues like this?
It's both. So doctors see many patients, and if they want to focus on doing only addiction treatment, it's completely feasible for them to see over 280 patients. especially if they happen to be someone who might just be in the area and someone's traveling and they need another prescription. Like, you don't necessarily need to have someone dedicated to only one doctor to provide them with their medication-assisted treatment. That's probably the biggest thing, just so you can have patient sharing among doctors and you can coordinate treatment that way. But the shortage of doctors being able to prescribe is probably the biggest limiting factor.
Really?
You need to get a license. And France had their own heroin epidemic in the 90s. And France looked internally and thought, what if we beat this thing by basically undermining the black market and allowing every single doctor in France to prescribe buprenorphine? They got rid of their licensing, and within 4 years, they saw an 80% reduction in opioid overdose rates.
I think we're in this weird place right now in the public policy discussion where the public and politicians would react negatively towards the idea of allowing doctors to prescribe more and to give out more medication. When we've just recently had scandals of, doctors being bribed to prescribe things that they don't need. They sort of view doctors in this way, and many offices as untrustworthy. I mean, do you think that that is the solution? We have to give more flexibility to doctors to give out more drugs? Because you have noted that opioid prescriptions have declined significantly in the past 10 years, but yet the death rate and the overdose rate has spiked.
So yes, I think public opinion and the opinion of people who are in the space to make decisions just has not been informed to note that prescribing rates have consistently decreased since 2011.
You never hear that.
You never hear that. Everyone says that these companies are causing addiction by over-prescribing opioids, and no one notes to the fact that we're in about the 8th year of a consistent decrease in prescribing. And it's no coincidence that the number of overdoses has increased, and the vast majority of that increase in overdoses, basically 100% of the increase in overdoses since 2011, has all been black market-related opioids, which are much more dangerous to consume than the types that you get from the pharmacy, which are prescription grade.
That seems to be a general principle of black market arguments when it comes to prohibition. Is there anyone in the 2020 field who you think is talking about this issue the right way, or it looks like they might be able to move in the right direction on the opioid crisis?
Absolutely not.
That's unfortunate. You mentioned Beto O'Rourke recently and sort of his dialogue on the issue as being pretty lackluster.
But I see him as actually much more of a blank slate than any other candidate. Beto has talked at Cato about ending the war on drugs. And he's kind of the only one who's taken that leap to say, drug policy in general has been done terribly, and we need to completely rethink the way that we're doing it. He also says that he's a blank slate, and he's open to new ideas. And I think he should start leveraging the data that the government is publishing. The government has published data that show that pain reliever abuse rates, non-medical use of pain relievers that are opioids, has been consistent since 2002. That kind of undermines an argument that he gave in New Hampshire, saying that we need to put pharmaceutical reps in prison who have made more people addicted. But if he just looks at our own data, he might see that the number of people who are addicted versus 20 years ago might not be that different. And then he can also point to the decreases in prescribing that have happened since 2011 and say, maybe all the presidential candidates around me are wrong, which they kind of are, and kind of just stick out that way. People are saying he's kind of like too similar to Buttigieg to pull votes away from other candidates, or kind of run into that situation. If you're too similar, you're not going to stand out, kind of like how Donald Trump stood out in the entire Republican primary in 2016. So I think he has the best bet of changing, but there's just too much investment in our government to continue the war on drugs. If we ended the war on drugs, there'd be too many people unemployed, and I'm just very cynical the more I look into the issue.
That is a cynical take, but
yeah.
I appreciate your honesty. Jacob Rich, thanks for sitting down with me.
Thank you so much for having me, Stephen.